Shaker, for giving me this opportunity to be with you all. I am an odd man out in this crowd because I am an orthopedic surgeon. As all orthopedic surgeons are, we are old in mind, young in mind, old in body. All these terms are confused. So the best way to understand elderly is when you look at somebody, he feels different. The best way to look at somebody is to look at the stars, which you know very well. And when they look differently, that means they are becoming elderly. This is a computer generated picture. Sometimes it is difficult to digest when somebody becomes elderly. And some of them do not become old at all. She is the same, whether it is 1982, 2002 or 2020. And at the inset is the man whom she loved most, and he has been getting older. So I think I have opened you up. So now let's start the actual talk. What is gait? Gait is unconsciously coordinated activity. It's the interaction between the musculoskeletal and the nervous system. If you look at the gait cycle, that means once the heel strike occurs, and when that leg is off the ground, and again the heel strike occurs, that is a gait cycle. It is basically divided into stance phase and a swing phase. Now if you look at the stance phase, where the limb is in touch with the ground. In the swing phase, it is off the ground. In a gait cycle, 62% of the time the limb is on the ground and 38% of the time it is off the ground. Now, even when it is on the ground, there is double limb support initially, then a single limb support, the whole body supported on one limb, then again a double limb support. In the swing phase, you have initial swing, mid swing and late swing. These terminologies have changed over the years of time. In the last 2 years, this is the terminology that is used for gait cycle. I don't want to go into detail of this because it basically involves heel strike, foot flat, mid stance, heel off and so on. That is the best way to remember. Every time you take a few steps, remember this, and that you will never be able to forget it later. What exactly happens when a person walks? Its heel strikes. That means there is dorsiflexion. Knee straight, hip is flexed. And then the foot becomes flat on the ground. As the foot becomes flat, the pelvis shifts over. When the pelvis shifts over, you will get flexion of the knee and the flexion of the hip. And then you get extension of the knee. To take the foot off the ground, there is plantar flexion. And plantar flexion along with knee flexion and hip flexion. This is how a person walks. What is gait disorder? If there is slowing in the speed of it, if there is deviation in smoothness, symmetry, or synchrony of body movements, then it is a gait disorder. If you look at person aged above 65 years, 15% of them have got gait abnormality. 40% at the age of 85 have got abnormal gait. Basically, a gait disorder can be either due to musculoskeletal, neurologic and musculoskeletal combined, or neurologic alone. So I will be dealing mostly with musculoskeletal, and one of these neurologic plus musculoskeletal, remaining will be dealt with neurology. Why did this gait disorder occur? Because it doesn't occur in corporates. This is mainly due to the erect posture of the man. Backache and gait disorders are the two things man get affected because of his biped stand or the erect posture. Why does gait disturbance occur? This is a big list. Either it is due to discomfort, decreased range of movement, decreased stability in one of the joints, disturbed motor power, disturbed length, or disturbed alignment. But in a person aged above 65, the gait is different. Gait is a bit different from a young person. It is classically described as cautious gait. He walks usually with short steps, steps are wider, there is double stance increase. That means he stands on both foot longer than others, and there is decreased hip and knee movements. This is because there is generalized degenerative changes in all the joints, muscles, ligaments, everywhere. He walks with a little bit stoop posture. There is flexed knee and elbows, decreased arm swing, and you get a type of gait called waddling gait, which I will deal with you later, in females. So look at this man walking. Cautious, small steps, wide foot, knee bent, hip flexed, stooped attitude, very cautiously turns, elbow flexed, turns back and walks. Very cautious in his walking. A classical gait in patient above the age of 65. Very helpful for his day-to-day activities. It almost prevents a fall most of the time. Most important gait disorder is an antalgic gait. What is an antalgic gait? It's a painful gait. Any painful disorder of the leg produces an antalgic gait. So what happens if there is a painful disorder in the leg? Then his stance space is decreased. He is keeping that limb on the ground for a shorter time than usual. That is common, whether the pain is from the muscle, from the joint, from the bone, or from the ligament, anywhere from that particular limb. And weight bearing on that particular limb is decreased. That's the basic criteria. He keeps that limb down or weight bears in that limb for a shorter time and takes the weight off as quickly as possible from that particular limb. It may be due to knee pain. It may be due to hip pain. Classically described as coxalgic gait. It may be due to ankle pain. Any painful disorder anywhere in the lower limb produces this type of gait. What happens? There is decreased walking velocity. The distance he travels in a minute or steps he takes in a minute decreases. Shortened steps and decreased knee movement when there is knee pain producing gait abnormality. So how does the patient walk? In a single, look at this patient. He is taking shorter steps. Bears weight on that limb at much shorter time when compared to the other limb because her knee joint is painful. She moves that knee lesser, takes off the knee away from that particular knee faster when she moves. Now what happens if both the knees are painful? See how the patient walks. She tends to have more time in a double stance. She keeps both the limbs together and waits, then takes one limb off, puts it forward, and as soon as possible takes the other limb and puts it forward. There is tremendous slowing of the knee, especially when you have this bilateral knee pain. What happens if there is hip pain? Entirely different. When a patient is entering your clinic, you can make out this patient whether he has got hip pain or a knee pain. The entire body lurches to the side of the hip. There is antalgic component. Antalgic component means there is painful limb. That means short steps, takes the weight out from the step faster. And there is component of step. Why does he lurch to the same side? We have learned in high school days this diagram that if this fulcrum, if the weight is put there, to balance this fulcrum, the weight into the distance is the force required on the fulcrum. What is this weight? Is the center of gravity of the body. It has to be shifted to the hip. So if you decrease this length, the weight into the length is the force on the hip. So naturally, the amount of force on the hip decreases if his center of gravity shifts to the hip when he walks. That is what the lurch is. Look at this. This patient doesn't have knee problem. She has hip problem. How she lurches to the same side? This is different in a patient who has got hip pain. Classically described as coxalgic gait. Coxalgic gait is very common in osteoarthrosis of the hip or any painful hip affections. If there is mild abductor weakness, you might get this gait, and in L5 radiculopathy, mainly due to abductor weakness you get. This is a common gait which makes an orthopedic surgeon either pass his MS exam or fail his MS exam. So Trendelenburg's gait and test is a common thing asked in every MS exam. If he is not able to describe this, he fails the exam. So what is this Trendelenburg's test? When the patient is bearing on this particular limb, this abductor is responsible, contracts and is responsible to hold this pelvis perpendicular position. If this abductor is not functioning well, this pelvis will sink. That is the basis of frenulum test. So if this hip is affected, when he stands on the affected hip, the normal side drops down. That is frenulum gait. Look at her. Now when she walks, this side of hip is dropping down. That is why this leg is longer, appears longer. She has to circumduct that leg to get it in front because the pelvis on that side has sunk down. How she takes this particular limb? She takes it round and gets it forward to move. And that is classically described as Trendelenburg's gait. So what's the difference? When both the gait, the patient is lurching to the same side. That is the difference. In coxalgic, pelvis is parallel to the ground. In Trendelenburg, patient lurches to the same side, but the pelvis is sinking. And that's the difference between a coxalgic gait and a Trendelenburg's gait. And most of the time, you can't differentiate between the two. So if you have extensor weakness, the torso tilts backwards because to get the center of gravity over the hip joint. There's no prize for identifying this gait. I think everybody knows it. Very present. What happens when there is knee contraction? If there is a knee contraction, patient has to exert more movement in some other joint. The most common joint which gets affected is the ankle. Ankle dorsiflexion has to be more. There should be early heel raise. The demand on quadriceps is much more when there is a flexion deformity of the knee. As a result, patient develops fatigue much faster if there is a flexion deformity. What is flexion deformity? Inability to fully extend the knee. Knee is flexed. So in this patient, there is a lot of demand on the quadriceps to walk, and invariably he or she becomes fatigued much faster. Look at her walking. She has to take rest after 3 or 4 steps, stand, and then again walk. Very classical of fixed flexion deformity of the knee. This is bilateral genu valve. In the very early stage of varus, whenever you look at the varus, there are 3 things you look at. Center of gravity is coming here. What is the distance of the knee from the center of gravity line? In an X-ray, whether there is lateral subluxation of the tibia. So how much, and is there a flexion deformity associated with the knee? These are the 3 things with which will decide what type of gait the patient will have. Now look at this, very comfortable in walking. There is varus, no lateral subluxation, thin lady, not much of weight going down, seems to be very comfortable in walking, even though there is so much of varus. Look at this lady, varus, but look at her X-ray. So much of subluxation. The entire biomechanics of the knee has spiraled. Because you have the ligaments, muscles, tendons oriented in different directions. They don't do the same job which they were doing before. How she walks, very difficult. Just because she has got subluxation of the tibia on the lateral side. She finds it very difficult to walk because of the altered biomechanics. Patient, when she has got associated flexion deformity, again becomes difficult to walk because she gets tired after taking few steps, has to stand, and then again start walking. So that is the problem when you have bilateral varus deformity with flexion. Give them a cane, they're perfectly all right. They walk well, they get a good support with the cane. So their exertion is reduced. So that is what happens when you have flexion, bilateral flexion deformity with varus. Unilateral varus is always a big problem because the other side is normal. Patient has to really make a very good effort to walk whenever you have this unilateral varus deformity. Now look at this. This is called duck waddle. She waddles on both sides like a duck on either side. That means either she has got bilateral hip problems. Both hips are affected. That's why when she walks, she shifts the weight to one hip, and again when she puts the weight on the other limb, shifts the weight to the other hip. Or she has got both the knee problems. That's why I wanted her to walk in a side, whether there is a bilateral genu valve. So these are the 2 common causes when the patient enters your clinic. Either she has got bilateral hip problem, or she has got bilateral knee problem. Or a patient who is aged 80 years, female without any problems can still have this type of gait called wagging gait. These are the three things one has to remember when you think that the patient is presenting to you with this type of gait. Unilateral or knock-knee. If it is unilateral, the patient is perfectly alright. Compensates it very well. If it runs for a longer time, the other leg goes into varus deformity, like wind swipe deformity, as if wind has swiped the knee to one side. Problem comes when there is valgus on the other side. This is one deformity where walking becomes very, very difficult. And even with the support, just see the difficulty that this patient has got to walk. Short leg, good compensation. Now what happens is he is also lurching. Actually he is not lurching, he is keeping his shoulder fixed down on that side to compensate for the length on that particular side. What happens? If we give him a heel raise, his gait becomes better than what it was before. So the lurch or the shoulder drooping on that side becomes less. This is how a patient with a stiff hip and stiff knee walks. Both the joints on that particular limb are stiff. Combined neurological and musculoskeletal. Till now I have talked about musculoskeletal. What happens if there is combined neurological and musculoskeletal? There are few diseases. Only one I will be taking, that is high stepping gait, which can be produced by, if you look at it, he is stepping it high. That means he is flexing the hip more, flexing the knee more. He doesn't have a heel strike. His toe first touches the ground and then becomes foot flat. That means he has got a lateral popliteal nerve palsy. That means he has got a foot drop. So foot drop can be produced either in the problems because of the spine, or the sciatic nerve, peroneal nerve, or the cut of the tendons of the dorsal spine of the ankle. All these can produce this high stepping gait. How do you analyze a patient? When a patient comes to you, it is not that you just observe the patient when the patient walks. It's imperative that you observe the patient when the patient gets up from the chair. That is where your observation starts. How does he or she get up from the chair? What does she use to get up? Which limb she propels forward first? And that's all things you look at. Then you look at them walking. Walking from front, side, and back. It may not be the same pleasant visual experience same time when you see them walking. Give them a difficult task to walk. Like ask them to walk uphill, downstairs, ask them to take steps, but don't tell them to do it and just observe. Show them how to do it. Then they'll be more confident following you rather than being asked to do it. Because these are all people who have suffered, they have almost finished their life, they are old age. And look at them, curious. Curiosity is the mother of all invention. Because these children were curious, we are what we are today. Because of them, all these inventions have been done. With all these, you learn all these things, you find out what's the cause. After exhaustive workout, you come to the conclusion that 1/3 of the gait disorders in elderly are multifactorial. 1/3 are treatable, 1/3 are non-specific and not treatable. That's the end point of gait in elderly. Still confusing? So looking at 4 eyes and 2 mouths, I think you need ophthalmology consultation. There are only 2 eyes and 1 mouth. Okay, this is our gait lab. We do a lot of work on our gait lab, and most of the work, unfortunately, not fortunately or unfortunately, is on children, not on old age group, because that's the age group we catch. Most of our work is on cerebral palsy. Few of our work is on adults in sports medicine group after their ACL and PCL reconstruction. Very rarely in old age group, because we don't find it lucrative to do gait analysis in old age patients. Whenever you give suggestions in these patients to improve their gait, be very, very cautious. If you give an advice like this, the best thing you can do is give up smoking, drinking and fried food. Definitely they are going to ask you what's the second. They have done it throughout their life. To improve their gait, this is not an answer. One of the answers, and because I am a surgeon, one of the answers is surgery to improve the gait. Surgery has advanced a lot. Because the anesthetic part has advanced a lot, death rate has come down per operatively. Our own operation theatres are better. We look like astronauts when we do the surgery, so that infection rate is less. Totally, patient outcome is much better after surgery. One of the surgeries is total hip replacement, which is done in arthritis, stiffness and instability. Look at this patient walking. See, just look at the speed at which he is walking. Forget about all those things. This is a patient after bilateral total hip replacement. And the speed at which he is walking shows how confident he is on himself. So this is just few radiological pictures of total hip, cemented and cemented. I am not going into detail. This is a hip where there is stiffness and arthritis on one side, instability on the other. So even these can be treated surgically by total hip replacement. It is did on one side, other side later. Look at the pelvis, how it is tilted even after 2 surgeries. Give us 6 months, square to square. It is got square and the patient's gait improves. Total knee replacement for pain, stiffness, deformity and stability. Usually you should not put the patient on this. Once if the patient is on this, even with the surgery, it becomes very difficult to take them off from a wheel walker. This a picture underwent on one side, which was a stiff knee. There was no movement on that side which got operated first. The other knee is 60 degrees, gets operated on the other side, and see the gait has improved tremendously just on the post-op day. So things have changed. This is how the fashion parade used to look in the early part of 19th century, mid-90s, later 19th century and in the 20s. So even the surgical skills and surgical environment have improved. I just wanted to show you this. This is a patient, bilateral flexion deformity. So much of flexion deformity is that she is not able to touch her heel to the ground. Because her flexion deformity gets tired whenever she walks a short distance. Very painful, not able to do her job. Underwent totally on both sides as a stage procedure. After the second stage, 10 post-op day how she walks. And this is her X-ray. This is how that has happened to the limb, the amount of flexion, and how she walks 6 months later. Almost normal gait. But patient expectation has to be good. You can't expect after the surgery to do all these things. These are once in a million people who can do all these stuff. There are errors, and to err is human, and everybody does an error. And more often, orthopedic surgeons, because their brain is quite small. Aim of our surgery is to make the patient more majestic, have a very well articulated walk, and be a social well-being.